We will move on to the next talk, Navigating Non-Infectious Scleritis, Expert Care. Dr. Dahlia, Senior Consultant, Medical Retina and Uvea at Srikanth Eye Care Hospital, will enlighten us about the non-infectious scleritis.
So good morning all. Thank you Dr. Anabi and Drishti organizing team for giving me this opportunity. So let's start navigating non-infectious scleritis with expert care. So some key points to note in case of non-infectious scleritis is that it's a rare sight-threatening inflammation of sclera which presents with red eyes. It is often associated with systemic disease which may be life-threatening. More the severity of the scleritis, greater is the risk of systemic disease. And we must always rule out infectious causes because the treatment is with systemic steroids, immunomodulatory therapy and biologics. Classification of non-infectious scleritis has been dealt with by Dr. Neetu beautifully, so I'll skip this. So there are multiple causes of non-infectious scleritis, but the most common is rheumatoid arthritis and granulomatosis with polyangiitis, what we call beginners before. So knowing these causes is important because we can ask specific history in the case of scleritis, which will help us to reach a causative diagnosis, like morning stiffness and joint pains in rheumatoid arthritis, ENT symptoms in GPA, malar rash, photosensitivity in SLE, and saddle nose deformity in relapsing polychondritis. So scleritis, it presents with redness and severe ocular pain. This symptom is so important that the patient comes with dull, boring pain which worsens in the night and disturbs his or her sleep. It is usually associated with headache. Decreased vision is seen in necrotizing scleritis and posterior scleritis. When we examine the case of scleritis, we see the congestion of deeper episcleral vessels with tenderness. This is important, tenderness with violaceous hue. And there will be scleral edema which causes the bowing out of the deep vascular plexus and no blanching with phenylephrine. In necrotizing scleritis, you may see areas of capillary and small vessel closure. It may be associated with peripheral ulcerative keratitis and anterior uveitis. It may also present with complications as elevated IOP because of the occlusion of trabecular meshwork or secondary angle closure as in posterior scleritis, or it may be steroid induced. It also presents with cataract because of inflammation and the steroid therapy. But the most important is the sight-threatening complication, the perforation of globe because of the scleral thinning as seen in necrotizing scleritis. So sharing a case, this is a 71-year-old female who came with redness and very severe pain in both eyes on and off past 4 months. History of multiple joint pains, diabetic hypertensive and cardiac patient. On examination showing diffuse severe congestion with scleral edema, peripheral corneal infiltrates and antechamber reaction. Blood investigation showed a very high ESR of 86 and RA factor strongly positive. So she was started on Indocup SR with resolution of the pain. Immediate rheumatology consult was done and started on deflazacort and methotrexate. On follow-up, there was scleral thinning, so opinion was taken to start cyclophosphamide or rituximab. Patient was not willing, but was started on tofacitinib along with methotrexate, and as it's now asymptomatic for the past 3 months on the treatment. So this is a case of bilateral anterior necrotizing scleritis with inflammation, with PUK and anterior uveitis associated with rheumatoid arthritis. In anterior scleritis, the diagnosis is mainly clinical, but anterior segment OCT may be used to quantify the extent of scleral involvement and thinning. We can differentiate diffuse with nodular scleritis. We can also see the scleral destruction, what we see in a necrotizing scleritis. It can also be used to assess the response to the treatment. The investigation of posterior scleritis will be dealt by the next speaker. So, should we investigate all cases of scleritis? The answer is a big yes, we should. So the investigations can be divided into 3 parts. The first is the baseline investigations to plan our management, which includes the CBC, ESR, CRP and blood sugars, the RFT and the liver function test. Tests to rule out infections like tuberculosis and syphilis and viral infections. To know the causative diagnosis, we do the tests like RA factor, ANA, C-ANCA, P-ANCA and urine examination. It's basically to rule out any renal involvement which is seen in Wegener's or polyarthritis nodosa and SLE and so many other conditions. So that's a very cheap test to do. So these are tests we should be doing in all cases of scleritis. And if there is any specific history, we can do the other tests also. In case you're suspecting an infectious etiology, local investigation, microbiological workup for bacteria and viruses should be done. In a case of scleritis, the treatment approach should be stepwise. So the first line of treatment is oral NSAIDs with or without topical steroids. In case the response is not good enough, we move on to systemic steroid. In case of therapeutic failure or to reduce the systemic steroids, we add on immunosuppressants. If the adequate is not good enough, we add on biologics. In surgical therapy, scleral patch graft or amniotic membrane graft, wherever indicated, should be done under adequate immunosuppression. To coming to immunosuppressive, site study has evaluated different immunosuppressants in scleritis, and they found methotrexate and mycophenolate to be more effective. Those are the first choices. Azathioprine is used in young patients who are planning a family because of the lesser risk. Cyclophosphamide is preferred in necrotizing scleritis. So a practical approach for the treatment of non-infectious scleritis would be do lab test. If it's a mild to moderate anterior scleritis with lab test negative and no positive history, start on oral steroids and with or without topical steroids. If the symptoms resolve, you can discontinue the NSAIDs and monitor for recurrences. If it's a mild to moderate anterior scleritis with lab test positive and positive systemic history, along with oral NSAIDs, do a rheumatology consult. If the symptoms resolve, again you can discontinue and monitor recurrences and also follow the rheumatological advice. If the symptoms do not resolve, if there is increased severity or recurrences, you go on to oral steroids. In cases of severe anterior scleritis, posterior scleritis, necrotizing scleritis, the first line of treatment should be oral steroids. In fact, in severe posterior scleritis and necrotizing, pulse therapy with IV methylpred should be given. In these cases, at the first instance, we have to do a rheumatology consult. If the symptoms do not resolve on this, or there is recurrence on tapering steroids, or if it is a necrotizing scleritis, we should start IMT at the first go. And it can be done with the help of a rheumatology consult. If the symptoms does not resolve with the added IMT, it may be the dose may be increased or an alternate IMT can be tried. In case of doubt, at this point, we should also rule out a viral etiology, and a trial of antiviral therapy can also be given if it is recurring with additional IMTs. The last resort, if in case of severe sight-threatening scleritis, is the biologics. So sharing one more case, a 64-year-old male came with redness and severe pain, worse in the night, and on examination had bilateral diffuse non-necrotizing anterior scleritis. All the blood investigations were negative. So initially started on indomethacin, but recurrence on tapering indomethacin. So we started on prednisolone, and but the sugars went high after 2 weeks. So immunomodulatory therapy was started with rheumatology consult. He was started on tofacitinib. There was no recurrence for the next 2 months, but he developed herpes zoster in the thoracic dermatome. So with the rheumatology advice, tofacitinib was stopped, and he was continued on low dose oral steroids, and oral antiviral therapy was given. And tofacitinib was started only after the herpes zoster was resolved after 1 month. And oral steroids were tapered and stopped. Now he's been asymptomatic for the past 4 months, and he's on tapering tofacitinib 5 mg in OD now. So this is a bilateral non-necrotizing anterior scleritis of unknown origin. So whenever you plan a cataract surgery in scleritis, something points to make notice: the eye should be quiet for at least 3 months. Adequate immunosuppression should be ensured before we proceed for the surgery. A bolus of IV hydrocortisone or IV methylpred perioperatively will help. Clear corneal incision is preferred, and post-op we should go for higher dose of topical steroids with very slow taper. Instead of high IOP, here hypotony is the most important point which you should look out for, because it is a sign of inflammation, and systemic steroids needs to be stepped up. So sharing this case of 40-year-old man, known case of SLE on treatment. He stopped HCQS 1 month post-cataract surgery and came with anterior diffuse non-necrotizing scleritis. And his investigations confirmed the diagnosis of SLE. So now the oral steroids were stepped up, and since he was not preferring HCQS, his treatment was changed to Folitrax. So to summarize, in the expert management of scleritis, meticulous history taking, detailed ocular examination, a targeted array of investigation with a multidisciplinary approach will help to find any underlying systemic cause. It also requires continuous interdisciplinary communication in the follow-up. So initial therapy often includes oral steroids. Oral corticosteroid therapy is the mainstay of scleritis therapy. Immunomodulatory therapy is utilized when the patients are refractory to systemic steroids or as an option for long-term management of ocular inflammation and also to manage the underlying disease. Biologic agents are being increasingly used in the management of scleritis, non-responding to conventional therapies. Thank you.
Thank you, Dahlia. That was a very good collection of anterior scleritis cases.